So just give a little bit of a background about why I was quite keen to do this webinar. So as John explained, I'm a team leader with the advisory service. I've been working with the Huntington's Disease Association now for about 2.5 years. Before that, my career started as a mental health nurse, and I was a mental health nurse for 30 years. And I was privileged enough to work with people with Huntington's disease for at least 15 years of that. I left nursing, or I tried to leave nursing in 2019 with a quick bounce back in 2020. And during that time, I did a career change and I trained as a reflexologist. And as a reflexologist, I had a small practice. And I was amazed at how many people that I was seeing who were coming to me for support with the menopause. So this took me down a route of exploring the menopause. And I have to say is as a mental health nurse, and this is no reflection on any other nurses out there, my knowledge about the menopause at that time was really quite limited. And I learned an awful lot. And I feel it's very, very important to continue to raise awareness about Huntington's disease, and the reasons for that we'll explore. Um, Menopause and Huntington's disease are both complex. Most people watching this webinar will be aware of the challenges faced by those affected by Huntington's disease, dealing with a lack of awareness about Huntington's disease from many health and social care professionals, as well as other people who they will come across. Menopause, it is safe to say that menopause can significantly complicate the experience of Huntington's disease due to the overlapping symptoms that we'll explore throughout this webinar. So although there has been much more of a focus on menopause in recent years, there is still a lack of awareness amongst the general population and medical professionals. So for a woman with Huntington's disease, or someone known to be carrying the gene or at risk, she's facing double the challenge and would be very, very lucky to get a healthcare professional who has got really good insight into Huntington's disease, into the menopause, and how actually those two could interact and complicate each other. So this is why I wanted to do this webinar today. So to do an overview of what we'll be covering is, first of all, is what is the menopause, and looking at some of the terminology that is used, a brief history of attitudes and understanding around the menopause and how that has developed in the recent couple of centuries, what is happening during the menopause and the impact that it's actually having on the body, focusing on that lack of menopause training and awareness, looking at some of the most common symptoms that will be experienced during perimenopause and menopause and how some of those overlap with Huntington's disease. And you will see throughout this presentation, there are some things that I've highlighted in red where there can be some contradiction, or it can be something that could cause confusion with somebody with Huntington's disease. Stress and the impact on menopause, research into Huntington's disease and the menopause. And one of the things I will be trying to do is don't get excited. There isn't research about Huntington's disease and the menopause, but looking at what is out there and looking at the impact of menopause on people affected by Huntington's disease. Treatments and ways to help people with the menopause. So the most important thing is knowledge, and that's what I'm trying to do today, is improve knowledge and really is signpost you to, there is so much information out there, so to make sure that you know where to go to find more information. Looking at HRT, and what I'll be trying to do is some of the research about HRT there are different studies over the last 20, 30 years with very contradictory outcomes, and hopefully be trying to help people understand what risks there are and the benefits, and then finishing up with lifestyle changes that can support the menopause. So the menopause, it happens or will happen to every single woman and transgender man. The NICE guidelines were updated and in 2024, and one of the changes in there was to be more inclusive and the recognition for non-binary and transgender men. It usually takes place in midlife due to a natural decline in hormones as part of aging. One of the things that we will look at is that age can change. It can also happen earlier because of surgery and other health treatments. So I know recently I had been speaking to somebody who, due to treatment for endometriosis, they had um, given her medication which would actually stop production of estrogen and therefore was having to be treated as the menopause. So whatever the reason, whatever the age, the impact is still the same. 75% of women will have symptoms. That means 25% won't. So 75% is quite a good chance. And as with Huntington's disease, there is no, this is how it is going to present. I found with people with Huntington's disease that I may work with somebody who I thought had a similar presentation or experienced something similar to somebody else, but everybody's experience was very different. And it is the same with menopause. And although you'll hear about certain symptoms, the extent of the symptoms and how it can impact is really quite broad. So although I will look at some of the symptoms, it is not an exhaustive list at all. So symptoms affect everyone in the family, and that is something, the awareness that needs to be raised is there needs to be a change. It used to be something that got whispered about the change, and but people don't understand. Does have a huge impact on people's health and well-being, and it has an impact on the person who's experiencing it, absolutely, but also those around them. And it is important that people around women can understand and can support. So first of all, to look at some of the terminology. So I've already used, I think, the phrase menopause and perimenopause, and there are differences. So premenopause or perimenopause is the time leading up to menopause. So this is average time is 4 years but it can be anywhere from 1 to 12 years. Now, this is what I read. I did work with a lady, actually through my reflexology practice, who was 14 years in. So hopefully you'll be on the shorter end, but it can take up to 12 years. Generally starts between the ages of 40 and 50. Like I've already mentioned, it can be a lot earlier. And also, like with many other things, it can be later as well. So this perimenopause, this is the time that describes the time from your first sign of menopause to the point where you've not had periods for 12 consecutive months. So that takes us then at the point where you've not had a period for 12 consecutive months. That is menopause, or sometimes referred to as postmenopause. So the average age to get to menopause or postmenopause is 51 in the UK, but it can happen earlier with premature menopause or later with late onset. So diagnosing perimenopause can be quite difficult because symptoms can come in quite slowly, and you might not notice. So changes can be quite subtle initially. Um, so over 45 years, you will be diagnosed as being in perimenopause because you have some symptoms and potentially irregular periods. Under the age of 45, it's when there are symptoms and increased follicle stimulating hormones in a blood test are identified. Now, some doctors may still request the FSH levels for over 45 years, but it's not reliable because you're going to see changes in that over 45 anyway. So, a brief history of the attitudes and understanding around the menopause. So, before we go through to the breakthrough news, what happened before that? So, we quickly just summarize some of the information that I found about the experience of women in menopause in Victorian times. Um, a woman's life expectancy was so short she would not have lived much post menopause. By the late 19th century, it was deemed scientifically proven that women's biology made them less rational than men, unfit to participate in many areas of public life. And a Victorian woman going through the menopause could be considered to be emotionally unstable. She may well have been prescribed leeching or bloodletting from the ankle, and her doctor would have advised against reading novels, going to parties, and dancing. So I think it's safe to say that we needed to move on from there and there need to be change. And thankfully, during the 20th century, there did start to be some breakthroughs. So estrogen was identified and isolated in St. Louis University in the States in 1929. In 1940s, the first estrogen tablet was developed and available in the USA. The feminist movement in the 1960s changed women's status and life expectancy, and this encouraged menopausal therapy and more study and more focus. Research into menopausal conditions began in 1960 and HRT was developed in 1960s. I had a look and it was available on prescription in the UK from 1965. So as you can see there, during the 20th century, there was quite a lot of progress with that isolation of the estrogen hormone to the development and the study of menopause. There was a study from the Women's Health Initiative that went, the study started in the 1990s and went through to 2006. In 2002, they reported on their outcomes. And they announced that while HRT has benefits, they were outweighed by the risks. Specifically, the study linked HRT to an increase in blood clots, stroke, and breast cancer. And decades later, this study has been shown to be flawed. And it was flawed in many ways because it focused on women over the age of 60, not the typical age of menopause, around 51, which skewed the results and overstated the risks of hormone replacement therapy. The study used an older synthetic form of HRT, not the body identical estrogen commonly prescribed today, and the results were misinterpreted by the media and the public. And this led to headlines like we see here today. But what did happen as a result of this, there was all of this misinformation out there. This report was absolutely grabbed on, and we saw a decline in HRT prescribing of 85% around that time. So it really did have an impact on the treatment and of menopause symptoms. We come into the 21st century and post this report and all these really negative headlines, attitudes towards the menopause have now dramatically changed. Symptoms remain, especially in Western industrialized society. There's lots of books, podcasts, research, nice guidelines, which were first introduced in 2015 and were updated in 2024. And of course, Davina McCall has done lots to raise awareness about the menopause. There's a lot of advice on natural management, and HRT is again recommended where there are menopausal symptoms, and I'll look at that further on in the webinar. Some of the information out there, there is a lot of information out there, but it's really important to go to some really good information and make sure that you are getting reliable information because there is quite a lot of unreliable. So the British Menopause Society educates, informs and guides healthcare professionals working in primary and second care on menopause and all aspects of reproductive health. I've put the link in here. Towards the end of the webinar, I've got a list of resources and I put that in. The British Menopause Society was established in 1989. They also have the Women's Health Concern. Now, this was initially established in 1972, and that is the patient arm of the British Menopause Society since 2012. That is a brilliant resource. They have got 20 odd different fact sheets, which are really, really good. I reference them quite a lot throughout this webinar. It's very easy to understand. It's very clear, and you know that it is up to date and you are getting reliable information. The NICE guidelines, like I say, 2015, but they were updated in 2024. Those are available and are available for healthcare professionals. NHS information about the menopause is a really good resource and a good resource as well for premature menopause is the DAISY network. All of these are summarised at the end, and we will make that information available to anybody who has attended. So to be able to understand how the menopause can have an impact and complicate somebody's experience of Huntington's disease, what we need to do is understand what is happening during the menopause. Trying to keep this presentation down to an hour, so we'll just go over. I could probably do a good hour just explaining this. So the hormones that are affected include, and not only, estrogen, progesterone, follicle stimulating hormones, testosterone and cortisol. The hormones affect many parts of the body, including the reproductive system, the brain, circulation, digestive system, liver, kidneys, immune system, central nervous system, muscles and bones. Hormones protect us against disease, such as osteoporosis, heart disease, respiratory disease, some cancers, arthritis. All of these hormones work very closely, and if one or more is too high, too low, or missing, it plays havoc in the body. And during perimenopause, everything is fluctuating, and that is why you get all of these changes. So during perimenopause, hormones begin to fluctuate due to the declining ovarian function. So the whole endocrine system works together. So the whole endocrine system works together to achieve homeostasis. But when estrogen lowers, lots of other things start to happen. And you will start to see the other things that happen and why that has the impact that it does. So the first one there that I've mentioned is melatonin decreases. And melatonin helps with that sleep wake cycle. So one of the first symptoms that many people do experience is disturbances in sleep. It may lead to thyroid disorders, cortisol increases, and affects how cells respond to insulin. When estrogen levels drop, the pituitary gland responds by producing more follicle stimulating hormone in an attempt to stimulate the ovaries. So if the ovaries are struggling to produce the estrogen, that is how the pituitary gland will respond by producing more FSH. Increased levels of follicle stimulating hormones can result in hot flushes, night sweats, irregular periods, and mood swings. Symptoms will vary depending on which hormone is the most dominant. And with everything fluctuating, that's why you will get different symptoms. Estrogen dominance, i.e. when estrogen is higher in levels than progesterone than would normally be, can often be the reason for experiencing an unpleasant menopause. So there are estrogen receptors all over the body. So they are in the reproductive organs, they're in the breast tissue, in bones, joints, ligaments, muscles and tendons, skin, cardiovascular system, the thyroid, the central nervous system. HRT protects against osteoporosis. This is one of the things that has been, but I'll go into that later on. So there is so much going on within the body, all of those systems which are being impacted. And like I say, going back to Huntington's disease, and we will have a look at the symptoms and how those overlapping symptoms can really complicate the presentation. There's lots of information out there that says that there is a lack of menopause training and awareness. What I wanted to do was not just come into this webinar and say that. So what I've done is I've had a look at what the Royal College of General Practitioners say. I looked to find some feedback from GPs, because that will be most people's first experience of liaising with somebody within healthcare, but also going to what women who have experienced perimenopause and menopause fed back. So the Royal College of General Practitioners states that the menopause is a key part of the curriculum for all GP trainees who must demonstrate competency into practice independently. And there were recommendations to Parliament recently that did say that there should be further training. These recommendations were not taken forward. Despite it being a core topic, there are reports that GPs are not receiving sufficient in-depth training on menopause. So I wanted to come on and give you facts and information rather than anecdotal things that I've been told. So I found the results of a study that took place in 2021, and this was an anonymous online questionnaire that was sent to GPs working within the NHS across the UK between January and March that year. The link to this study is below and it's in the resources at the end. I think this makes some very interesting reading. So 52% of GPs indicated they were not offered enough support to be able to advise and treat women with menopausal symptoms appropriately. 77.5% of GPs express that there is a need to improve training provided in menopause in medical school and GP training. 60.7% of GPs felt comfortable managing menopausal women and offering them management options. That means just short of 40% of GPs don't feel comfortable, and that is concerning. And 22.5% of the respondents felt that the NICE guidelines are easy and clear guidance for clinical practice. One of the things that I do want to say is there has been an update to the NICE guidelines in 2024, and this questionnaire, this research was completed in 2021. However, that is still relatively new, and I think it does make the case that there is a need for further training. And when you do I did have feedback when I was working with people and from their experience with GPs that suggested that NICE guidelines weren't being followed and suggested that GPs weren't comfortable and that people weren't always getting the best experience. So I do think it is interesting to see the outcomes of that study. Then I wanted to, again, I can find all sorts of anecdotal things, but I wanted to find a piece of research that fed back some of the experience that women had. So I found Healthwatch Hertfordshire 2023. So the Hertfordshire and West Essex Integrated Care Board asked Healthwatch Hertfordshire to investigate the experiences of perimenopausal and menopausal women when accessing GPs. And actually, when I had a look, there are quite a few Healthwatch studies around the country, but this was one of the later ones. So I felt that this was good to share today. So 52% of women had to speak to healthcare professionals about their menopause symptoms multiple times. Many spoke to several different doctors before they were taken seriously and were initially misdiagnosed. And this does go in line with some of the anecdotal things that I got told about. So 52% that's more than half. And again, this sort of fits in with the numbers that we're hearing with the GPs. Some women said they had such a poor experience, it prevented them from getting further help despite having severe symptoms. Concerningly, a few were told by healthcare professionals what they were going through was part of life, refused treatment, and told to just get on with it. Women going through early menopause found it harder to get diagnosis and support. Some respondents said they were unaware that women could start the perimenopause in the 30s and 40s. And respondents felt more individualised treatment was needed since experiences of the menopause could vary enormously between women. And it is just worth mentioning that the NICE guidelines, I felt, having reviewed them, are quite clear and is a good, strong guidance. I think it is important that people are aware what is in there so that they know what they should be expecting and what they can ask for when they are looking for support with the menopause. So although there is still work to do, there has been so much progress. So hopefully we will see that progress continue. So we've looked at what menopause is, some of the problems that people are still experiencing about getting support. So just looking at some of the symptoms, and like I referenced at the beginning, there are the complexities and there with Huntington's disease because there are some overlaps that could lead to things not being noticed, not being picked up, or misdiagnosed, or diagnostic overshadowing. So I'm not going to sit and read out all of these, and this is certainly not an exhaustive list of symptoms. You do very often find if you speak to a GP that they will very much focus on hot flushes, which lots of people do experience, but there are an awful lot more symptoms. So just to focus on the ones that I've highlighted in red, because of the problems with temperature with Huntington's disease, it is possible that somebody who is experiencing perimenopause could be having hot flushes, night sweats, and clammy, and it could be that you could misinterpret those as problems with your temperature control associated with Huntington's disease. Irritability, mood swings. Again, this is something that could be considered either early stages of Huntington's disease, or with somebody who has got Huntington's disease, it could be considered that actually this is due to Huntington's disease, and it may be that people don't consider, could this actually be perimenopause? Insomnia, again, with Huntington's disease, you do get changes in sleep cycle, but it is part of perimenopause. You do get changes to libido with Huntington's disease. So again, this is something else that can be misinterpreted. Fatigue, energy problems, and fatigue can be experienced through Huntington's disease, as can anxiety and depression. And because there are some cognitive changes that can be experienced with Huntington's disease, you could misinterpret poor concentration and poor memory as symptoms at the start of Huntington's disease. So somebody who has got Huntington's disease, or somebody who is at risk or gene positive, these are symptoms that could cause concerns, and they need to be really looked at and explored to see what could be going on. But we'll look at each of the groups of people affected by Huntington's disease and things to consider as we move through. So the most common menopause symptoms, so this is the postmenopause. So this is when somebody hasn't had a period for more than 12 months. So again, those vasomotor symptoms. So just to explain, the vasomotor symptoms are the hot flushes and the night sweats. Depression and anxiety, again, are persistent throughout and can continue into postmenopause. That poor concentration and mental confusion, irritability, mood swings, and insomnia. But for anybody trying to understand Huntington's, to understand the menopause and the perimenopause, hopefully to see all of these symptoms, but again, they are not exhaustive at all. And I have to say is I was quite surprised at some of them. And lots of people who I worked with started with allergies. They strange amount of people experiencing tinnitus and itchy skin. They were problems that a lot of people were experiencing. So menopause and the brain. So again, just touching on this, the brain has estrogen and progesterone receptors. Estrogen and progesterone do not only affect the reproductive system, and that is one of the things. It's so important to understand why the symptoms and the impact of menopause affects the body as a whole. It isn't just about the reproductive. So there are receptors in the brain for estrogen and progesterone. As hormone levels become erratic or decline, the brain has to adapt, and this impacts on mood regulating chemicals, including endorphins and serotonin. So endorphins help relieve pain, reduce stress, and improve your sense of well-being. Serotonin is a chemical that carries messages between nerve cells in the brain and throughout your body. Serotonin plays a key role in such body functions as mood, sleep, digestion, nausea, wound healing, bone health, blood clotting, and sexual desire. So the impact is right across the body. Hormone levels initially are erratic, and changing levels can impact on how someone feels and their behavior. And it is that changing that has that impact. So again, highlighting in red that with those changes, it can be perimenopause, can be a time of mood swings, rages, crying, feeling terribly hurt, losing control of emotions, being unkind, sad, and irritable. And incidence of depression double in perimenopause, usually with those who've had previous mental health problems. So again, for somebody with Huntington's disease, we're looking for mental health issues anyway and need providing that support. But it isn't necessarily going to be Huntington's disease, and we need people to be thinking with women, could this be associated with menopause? And it may not be Huntington's disease. With menopause and the brain, one of the things we do look later on about the things that we can do to help with menopause and reduce some of the symptoms and reduce some of the impact that these changes have on the body, but reducing stress and exercise can make a huge difference. So stress and the impact of menopause. So chronically elevated cortisol levels increase the likelihood of a severe menopausal symptom. So when we're stressed, we produce cortisol and adrenaline. So while adrenaline provides an immediate surge of energy and alertness, cortisol provides a more sustained energy boost and keeps the body on high alert for a longer period. Cortisol plays a sustained role in that fight or flight response by providing energy, increased alertness, and suppressing non-essential body functions to help the body deal with immediate threats. And that is what can cause a lot of anxiety and a lot of problems that we do associate with chronic stress. So the adrenal gland produces adrenaline and cortisol, but if you are stressed, it will produce adrenaline and cortisol rather than estrogen and progesterone. So although your ovaries are producing estrogen, your adrenal gland also produces estrogen and progesterone in much smaller amounts and small amounts of testosterone as well. So if your body is in a continual fight or flight response, or if your body is very stressed, the building blocks that are used to make that estrogen and progesterone will go into the production of adrenaline and cortisol. And just to complicate this even more, estrogen and progesterone dampen the effect of cortisol. So you feel that effect of cortisol on your system far more if you haven't got estrogen and progesterone. So symptoms of high cortisol are similar to perimenopause. So that is low mood, anxiety, low energy, insomnia, bloating, low libido, and sex drive. And chronic stress, so that raised cortisol can lead to depression, weight gain, fatigue, especially in the morning, muscle weaknesses, craving sugars. So this is why if your body is going through the menopause with all these hormonal changes and all of this impact, this is why it is a time in life to really try and reduce the impact on stress, because otherwise you've got those two things going on. So like I did try and say in the overview, please don't get overly excited that I'm going to announce all of this research into Huntington's disease and the menopause. I've put here there is a lack of research specifically focused on how the menopause affects Huntington's disease. That is me saying I didn't find any, but I'm not saying that I've done an exhaustive search, but I didn't find any. There is some research about the impact of menopause and other neurodegenerative conditions, such as Alzheimer's disease and Parkinson's disease. These pieces of research focus on loss of estrogen in menopause due to estrogen's neuroprotective factors. Research suggests menopause is associated with an increase in some neurodegenerative disease, but there is nothing specific to Huntington's disease. If while I have been looking for pieces of research, I have found suggestion that there is some ongoing research into the effect of estrogen and Huntington's disease, but I haven't found any conclusions about that. And I haven't really sort of found this particular study is looking at this. I think what is clear is that menopause can significantly complicate the experience of Huntington's disease due to the overlapping symptoms. So on that, we have looked at some of the symptoms and how they can be impact on people with Huntington's disease. So I wanted to look at the different groups of people affected by Huntington's disease. So people who are symptomatic, and I think the main thing here is not everything they experience is due to Huntington's disease. And there is a real risk of diagnostic overshadowing where because somebody has Huntington's disease, everything that changes, everything new, everything that gets a little bit worse, or they get an exacerbation of, it can be put down to Huntington's disease. And when you're looking at Huntington's disease where there's a lack of awareness, and with menopause where there is certainly room for more people to be to improve their experience and the support that they give people, there is a real risk of diagnostic overshadowing, and because so many of the symptoms do overlap. So this should be considered. One of the things I said at the beginning that I had the privilege of working with people with Huntington's disease for 15 years, and that was because I found it the most rewarding work that I ever did because you got to know people, and I found that it was problem solving, it was getting to know people, it was looking at what was going on, understanding what potentially their experience could be, and trying to problem solve what the issues were to overcome changes in behaviour and barriers to delivering care. So problem solving is such an important part of Huntington's disease. And one of the key messages that I really want to take away from today's webinar is that you need to be thinking when you are problem solving. And I know people will say not everything is going to be Huntington's disease, but when you are working with women who, yes, are between the ages that you would expect for menopause, but we do have early menopause or certain treatments or certain surgery, you are going to have this impact. And it's about identifying what actually is at the root and considering things other than Huntington's disease. It is important to keep diaries of behavior, mood, menstrual cycle to help identify whether there is a connection with hormonal changes associated with the menopause. I think one of the things that certainly if you're supporting people with Huntington's disease is my experience was when I was looking after people was that it was actually me who took that as a suggestion. I take the credit, actually. It was probably my team who brought it to me, and I then took it to the doctors. And very often the doctor maybe hadn't met them before, didn't know much about Huntington's disease, had read a little bit about Huntington's disease, saw a change in behavior. That works nicely. And it is those people who are supporting, whether that be family members or within a care setting, you having that awareness, you asking those questions and you being aware can certainly start those questions. So the reduction in estrogen is known to impact on other neurodegenerative conditions. There is no conclusive research in HD, but menopause can significantly complicate the experience of Huntington's disease because of those overlapping symptoms. One of the things that I really don't want to go into too much depth about because I do not feel qualified to do is that there are significant metabolic changes and metabolic syndrome increases in menopause, and Huntington's disease affects the endocrine system, leading to a variety of metabolic changes, including an increased risk of diabetes and I'm going to stress hormone levels with cortisol. In menopause, because of the decline in estrogen levels during the menopause, it can lead to a cluster of conditions, including high blood pressure, high blood sugar, unhealthy cholesterol levels, obesity. So you've got metabolic changes and risks going on with the two conditions. So it's just something to be aware of. And if there are any of those, but with both of them, there are increased risks So that is just something to highlight, but I'm not going to go down and start doing a comparison about how they all interlink and how they all work together and impact. That is for somebody to research and conclude and report on at a later date. Um, Lifestyle changes are so important when you're managing the menopause. And as I go later on into the presentation and talk about some of the things that we can do, it is worth acknowledging that it can be a challenge to introduce some lifestyle changes for somebody with Huntington's disease, but there's also opportunities as well because routine, once something is within routine with someone with Huntington's disease, it can be easier to maintain that. And also is when you do need to introduce something, actually having something other than it being about Huntington's disease, this will help with your menopause. It may well work. So these are things that are to be considered when you're working with somebody with Huntington's disease, but do recognize there are challenges, and I'll reflect on some of those as we go on. So we looked at people who are symptomatic, people who are at risk or gene positive. The average age of onset for HD is recorded as 30 and between 30 and 50. As we all know, it can be much younger, it can be much later. The average start of the menopause is 45 to 55, although it can vary significantly with and begin earlier or later. And 75% of people will have symptoms. So for somebody who is at risk of Huntington's or knows they're gene positive, all of these symptoms can start around around the same time. So that awareness and understanding about menopause is so important. So you can understand that there would be a potential to believe symptoms are associated with Huntington's disease that could be menopause. And that is something that should be explored. Discussed about the impact of anxiety and stress and if you are worried that you've got that menopause symptoms are actually Huntington's disease, that is just going to make your symptoms worse. It's important to ensure that people understand and have information and are educated about menopause earlier on, and that information is available, and it is out there and it is there now. But this raising awareness and looking at this is something else to be considered when you're looking at the future. And so looking at the future and looking at resilience and preparing for the future, some of the consideration of the lifestyle changes may be beneficial, and that might be something that somebody who is gene positive or at risk wants to think about earlier. And I didn't want to forget when we're looking at people who are impacted by Huntington's disease, carers. So the impact of stress on the symptoms of menopause. So experiencing menopause whilst you're caring for a family member can be challenging, as caregiving responsibilities can worsen symptoms like fatigue, anxiety, and insomnia. And I think it is safe to say can certainly increase stress and the impact that that can then have on the experience of menopause. So providing care whilst experiencing menopause with increased irritability, mood swings, and fatigue has got to be incredibly difficult. And therefore, it is very important that the caregiver gets diagnosis, gets support, and prioritizes their own well-being, and people around them support that and enable them to have opportunities for relaxation. I didn't want to go through people affected without that reference to the carers and the support that is needed and the importance of their well-being. So treatments and ways to help with the menopause. So first of all is knowledge. There is information out there. If you understand all of what is happening with the menopause and know where to go and get support, that is a good starting place. HRT, I've already covered a little bit within the history. We'll go into that a little bit more. One of the changes with the 2024 NICE guidelines was the recognition that cognitive behavioral therapy can have specifically for vasomotor effects, does have, and it is now recommended. and then lifestyle changes. So diet, exercise, relaxation, sleep, and smoking cessation. So HRT, you can have combined estrogen and progesterone, which can be given with tablets, patches, or an implant. You can have estrogen only. Estrogen only tends to be following a hysterectomy, progesterone only, and testosterone for libido, fatigue, and low mood, but only usually considered for women whose symptoms persist after standard estrogen-based therapy. I've already referenced the NICE guidelines. There is a link that is also in the resources at the end. There are common side effects with HRT, but they're usually short term. So these include bloating, abdominal pain, indigestion, nausea, breast tenderness, edema, headaches, migraines. Um, Most of those can be short-lived. It is very, very important, and the NICE guidelines do talk about this need for it to be individualized. There is not one size fits all, so it is important that you will be started off. The aim is to have people on the lowest dose that is effective for them. So you will be started off on lower doses. But it is important to keep speaking to your GP to find the right level and reporting any side effects that people are experiencing. So again, if you're supporting somebody with Huntington's disease, keep maintaining that diary when somebody starts on HRT. There are benefits. It is effective at reducing menopausal symptoms. I will go on to the research in the next slide, but that is the evidence that it does work. My experience of working with people who had HRT is some people were a little bit indifferent about whether it was doing. Some people said it was absolutely life-changing and really did make a huge difference for them. One of the things just that again I've highlighted in red there is because of certainly later with Huntington's with the risk of falls, it does decrease the risk of fragility fractures whilst on HRT, and there is evidence that it can improve mood. So these are things to be considered when working with somebody with Huntington's disease. So, as I've mentioned, there has been quite a lot of research which has been contradictory and has led to confusion. So, in 1990, the research said it was effective in reducing symptoms, reducing coronary heart disease, hip fractures, colon cancers, and Alzheimer's. These were the claims that were made at the time. 1997, HRT should increase life expectancy for nearly all postmenopausal women by up to 3 years. That claim has absolutely now been disproved. 2002, this prescribing virtually stopped with the American study. As I mentioned before, it was a flawed study. It was a biased trial. There was inaccurate reporting. The average age was 63, half were smokers, and 70% were obese. So this was not a good study. The current guidance, and I've taken this from the Women's Health Concern, which is the patient arm of the British Menopause Society, is although there have been concerns raised about HRT and the potential risks to various aspects of women's health, more recently published findings show that although not entirely risk-free, it remains the most effective solution for the relief of menopausal symptoms and is also effective for the prevention of osteoporosis. It may in certain age groups provide protection against heart disease. So all of those earlier claims that you can still find out there on the internet, please look at the most recent guidance. In the resources, I do put a link into a short 20-minute video that is on YouTube by Davina McCall, which explains the risk, because I think one of the biggest concerns about HRT remains the risk of cancers, blood clots, but it's mainly the cancers. Your GP will check with you if there is a history of blood clots, that will be looked at and that will be considered. So it's important that you have that consultation with your GP and you're open with them so that they can prescribe appropriately. But I wanted to put into context the actual risks associated with HRT, and that video does horses. So looking at HRT, there's also lifestyle changes. So the way we live our lives has a big impact on the menopause. So changing your normal way of eating can reduce symptoms. One common mistake is the assumption that taking hormone replacement therapy means you can ignore diet, whether or not you use HRT. What you eat and drink matters for day-to-day symptoms and to manage longer-term changes to health. That is a quote directly from the British Dietetics Association. And a healthy menopause lifestyle needs to include exercise to support mind, body, and soul. Even if you've never exercised before, now it's time to find out what works for you. And that comes from Women's Health Concern. And like I say, Women's Health Concern is the resource that I really would be going to. So diet, just having a look at what is happening with the menopause, the effects of low estrogen levels, it may cause body fat to be redistributed, hence the change in body shape. Laboratory animals tend to eat more and be less active. Cholesterol rises, may lower the metabolic rate. Body is less effective if using carbohydrates, which can increase fat storage and can affect sleep, which can lead to cravings for sugary and starchy food. So looking at to eat a healthier, balanced diet, including eating more fiber-rich foods, beans, soy, and pulses, achieving at least 5 different vegetables and a fruit a day, and opting for more frequent plant-based meals can make quite a difference. And I did see a lot of people really improve their symptoms through diet. A good link there to the Women's Health Concern. Due to Huntington's disease having an impact on the endocrine and the metabolic system, it is important to work closely with a dietitian for anyone symptomatic of Huntington's disease if you're going to be approaching diet as a way to support with symptoms, because we obviously there will be considerations about the risks of somebody losing weight with Huntington's disease. Exercise is crucial during menopause to manage hormonal changes, and it helps improve heart health, maintain bone density, manage weight, and boost mood. The decline in estrogen increases the risk of conditions like osteoporosis and heart disease, but regular physical activity, including strength training and cardio, can counteract these effects. Exercise also helps with sleep disturbances, anxiety, and weight gain, commonly associated with this life stage. So there are some general principles of exercise there, and I won't go into too much depth with them, but what I would say is work within your limit and work up. Do not try and um, overpromise and set yourself up to do this huge regime of exercise that you're not going to be able to achieve. Small changes. When I worked with people with menopause, it was always, let's find a small change of something that you're going to enjoy, and set yourself up for much lower than you're actually going to do. The British Menopause Society also recommend regular weight-bearing exercises, walking, jogging, skipping, and tennis. It says to vary your exercises and keep fit and flexible to reduce the risk of falling with things like yoga, tai chi, and Pilates. I thought it was worth putting in here. Obviously, somebody symptomatic with Huntington's disease, due to career movements and balancing gaits, it's important to consult a physiotherapist to adapt an appropriate program of exercises. But I thought it was really good to signpost everybody to our resource, Keeping Active with Huntington's Disease. This resource provides information and tips and hints on how to make a physical activity plan that is unique for a person with Huntington's disease. The resource was developed by researchers at Cardiff University, the Huntington's Disease Association of England and Wales, Carers Trust Wales, and Carers and People with Huntington's Disease. There is a link there to that resource, which is available on our website. CBT, I mentioned before, this has now been added and recognised as a non-medical approach that can help with menopause, particularly the vasomotor symptoms. It can also help with a range of health problems, including anxiety and stress, depressed mood, hot flushes and night sweats, sleep problems and fatigue. Relaxation, I talked earlier about how important it is to manage stress. So it's important to make time in the day to make time for relaxation. And I know lots of people who are very stressed and very, very busy find it very difficult to do this, but it is so important. And hopefully, by seeing what is going on and the importance and the impact, this is something, if this was only going to be your first change, this would be the one. Find time for relaxation. And that could be through visualization, relaxed breathing techniques, and relaxing to calm music and meditation. And mention their complementary therapies. The NICE guidelines are clear. There is not evidence that complementary therapies can treat menopause symptoms. However, there is scientific evidence that complementary therapies can help with stress. And if you can reduce stress, that will help with some of the symptoms of menopause. The impact on stress on the body when hormonal levels reduce. So the stress, when that estrogen isn't protecting you, it can lead to difficulty concentrating, struggling to make decisions, feeling overwhelmed, being forgetful, unhealthy habits. And that is just going to add to your stress when you're trying to work through that. So again, just try and make sure that you do make that time for relaxation and you do prioritize and recognize the need to put yourself first and put that into your routine. And the importance of switching off that stress response. It helps improve sleep and it reduces the cortisol levels. And the cortisol level, as well as everything else, it produces that anxiety, muscle tension, and digestive problems. So just a few other lifestyle changes. Sleep, so maintain a regular bed routine. Again, with somebody with Huntington's disease, that can be a real challenge. Again, if you can get somebody into a routine, it is helpful, but it will help with menopausal symptoms. So if it is something that you can focus and support and build into routine, that is good. Good sleep hygiene, so avoiding the use of phones and electrical items before going to bed. Again, thinking about, a lot of people do experience the hot flushes at night, so wearing lighter breathable clothing to bed, decrease the general room temperature to 18 degrees and consider using a fan, and avoid caffeinated or alcoholic drinks within 6 hours of your bedtime. This was when I used to discuss lifestyle changes. The alcoholic drinks to stop were never popular, but the benefits that people did get when they did reduce those and make those lifestyle changes. Declining hormone levels can affect the body's fluid balance, and adequate hydration can have a impact on your symptoms like headaches, fatigue, brain fog, joint pain, dry skin, supporting overall health, digestion, and cognitive function. So ensuring you are hydrated. These are things that we talk about for well-being, but when you're going through the menopause and you're having those changes, it is even more important. So again, if it's a change that you've not managed to make, it is something to look at. Smoking, I've put this in red from my own experience of working in a care setting for people with Huntington's disease. Smoking for a lot of people was a big part of their day, and they were very focused on it. And I absolutely acknowledge that it can be a real challenge to encourage somebody with Huntington's disease not to smoke. If you've got the information about how that can actually impact on menopause, if you've got information, people can make more of an informed decision. So first of all, smoking can cause earlier menopause and it can worsen symptoms by disrupting hormone production and increasing the severity of hot flushes, sleeping difficulties, and anxiety. So if people are experiencing that, again, trying to negotiate with them to stop smoking, even if it's for a period, to see if it does help. And like I mentioned earlier, that avoiding alcohol, cut down on alcohol levels, as low mood can be exacerbated and sleep is disturbed by regular use. General dehydration can lead to decreased energy levels. So all of these things are things that we should do to look after ourselves, but they have so much impact. And that's why I go into what is going on in the body and all the symptoms you experience, so that actually you can help people make an informed decision about what changes they should be making and how they can help themselves, as well as the other treatments. I haven't got on to do a summary slide. I think in summary, it is about making sure that people have got information, raising that awareness, recognizing that the menopause can really be a far more difficult time for somebody with Huntington's disease, that so many symptoms do overlap, and being aware of that risk of diagnostic overshadowing. These are the articles that I've used and read